Okay, I think we'll kick off. First of all, many thanks for all of you that have joined to join us in this discussion this afternoon. The meeting or the briefer that we just launched last week, please feel free to download. We'll put the link in the chat as well. Defeating the double standard in diabetes care. And we're starting today focusing on insulin, so lowering the price of insulin everywhere. How can we really make that a reality? So just before we get into the interesting stuff, just a bit of housekeeping. We're going to do just a few presentations to kind of, let me say, set the scene. I know in the room we've got some very seasoned diabetes experts and advocates, but I think also we might have some access to medicines and even some HIV civil society folks who might not be so familiar with the topic. So a general introduction. Then we're going to look at an insulin device user preference survey that we carried out, and then dig in to look a little bit around what the manufacturers are doing on access to insulin and how much insulins could cost. We ask you to feel free, introduce yourselves in the chat and write your questions and comments in the chat. And then at the end, we're hoping that we're going to have some time for discussion. So if you would like to contribute or ask a question, then please raise your Zoom yellow hand and we will unmute you to bring you into the conversation. So just as kind of setting the scene, a few slides that I'm going to kick off. And sorry, I should have introduced myself. My name's Dr. Helen Bygrave. I'm the medical technical referent at MSF Access Campaign, working on the diabetes dossier. So today, over 500 million people are living with diabetes, and 3 in 4 of those people are living in low and middle income countries. 6.7 million deaths due to diabetes in 2021. And I just wanted to put that graph on the right, showing what we're going to be looking at over the next 20 years or so, is this exponential increase in the number of cases of people living with type 2 diabetes, with an estimation that this is going to be around 1.3 billion people by 2050. So a massive public health concern. And what's interesting is when we look at where those increases in number of cases is going to happen, sub-Saharan Africa is one of the areas that's going to see the biggest increase in the number of cases of diabetes. If we think now, look then about the numbers of people living with type 1 diabetes, and I'm going to just explain a little bit more about that shortly. There are approximately 9 million people living with type 1 diabetes globally, with 1.2 million of them being children and adolescents. The data on this is, let me say, needs quite some work. But these are the current estimates in terms of people living with type 1 diabetes out of that 537 million. So who needs insulin? There are 2 main types of diabetes. There are several other types, but for today's conversation, we're going to talk about type 1 diabetes and people living with type 2 diabetes. So people living with type 1 diabetes, they absolutely must have insulin to live. Yeah, they are unable to produce insulin, and it is an immediate life-saving medicine. People living with type 2 diabetes are able to produce some insulin, but it doesn't work as well as it should. And approximately 10 to 15% of people living with type 2 diabetes will go on to need insulin after using other glucose-lowering medicines. This proportion of people may start to change as we see the introduction of some new medicines for type 2 diabetes, which we're going to talk about in our webinar tomorrow. So what's the total global need? As I said, all 9 million people with type 1 diabetes absolutely need insulin now and today, without which they will die within days. And from MSF's perspective, in the humanitarian setting, in emergencies, having insulin immediately is a kind of a life-saving intervention in a humanitarian emergency. But let's say approximately 60 million people with type 2 diabetes will also need insulin. So in total, around about 69 million people globally require insulin for their diabetes management. I just wanted to flag a couple of high-level WHO, World Health Assembly documents that really have just recently happened. Yeah, diabetes is not a new condition. We've known about it for decades. But in 2021, we got the first World Health Assembly resolution on diabetes. And I just pulled out one kind of paragraph from a very long document to flag that countries have signed up, and this is a note to national governments, that they should be promoting access to diagnostics and safe and effective essential medicines, including insulin. And this is a tool potentially that we can use as advocacy with our national governments. Also out of that resolution in 2022, for the first time, I think many of us are used to the 95, 95, 95 HIV targets, but 2022 was the first time that we saw global diabetes targets being announced and agreed by member states. So you will see there 80% of people with diagnosed with diabetes should have good control of glycemia. And the last target, which I've never seen WHO giving a target of 100% for anything else, but this is a point of debate, that 100% of people with type 1 diabetes should have access to the insulin, medicine, injection devices and monitoring tools that they need. Just to introduce the issue around the insulin market, today in 2024, basically we have a triopoly. 3 companies control 90% of that market. That is Novo Nordisk based in Denmark, Eli Lilly based in the US, and Sanofi based in France. Just as an aside, Novo Nordisk and Eli Lilly also control the GLP-1 market, these new medicines for type 2 diabetes, also used for obesity. And on the back of the GLP-1s, Novo Nordisk is now the largest company in Europe, not the largest pharma company, the largest company, overtaking Louis Vuitton. And Lilly is heading towards being a $1 trillion company. We also wanted just to flag, and I'll say from our side in the MSF Access campaign, this is definitely something that we want to start to understand better, is the Novo Nordisk Foundation. Founded actually 100 years ago, I discover, with the goal that profits from the sale of insulin would be used for the public good. However, when we look, we see that the foundation holds 77% of votes and 28% of shares in the company. And so I think the interaction between the foundation and the company will be undoubtedly inextricably linked. And already last year, they gave out $1.3 billion in grants. So this foundation, I think we need to have our eyes on it. I think many of us, have been aware of, the Gates Foundation and their role in a range of public health and international health endeavors, but how is the Novo Nordisk Foundation moving into this arena? And we see last week announcement, Tedros, head of WHO, welcoming Novo Nordisk Foundation somewhat into the fold. So for people who, for us, for anybody in the audience who's new to the diabetes kind of world, I just want to try and just to introduce some of the terms and that we're going to be talking about in the next hour. So just to say, to keep it simple, there are 2 types of insulin that we have in the market: human insulin or analog insulin. And all that's happened with analog is that the molecule has just been tweaked slightly so that it can either act really fast or it acts over a longer period of time. And bottom line, this just helps people living with diabetes have much more flexibility around how they can use the insulin. Both human insulin and analog insulin can come in 3 different presentations. So on the left, it can come in a vial, and that needs to then have an insulin syringe. You have to use that to draw up the insulin and then inject the insulin under the skin. In the middle, there is a reusable pen option where you insert a cartridge into a reusable pen. But the important point to make for this one is that one company's cartridges cannot go into another company's pen. So the cartridges are designed for the company's reusable pen. And then finally on the right, these are pre-filled pens. They have insulin inside. They have a kind of a little dial-up thing at the end of the pen where and you can dial up the dose that you use. You do need to screw on a pen needle to both those reusable and pre-filled pens to inject the insulin into the body. So over 100 years ago, insulin was discovered. We started with animal insulins. 1977 saw human insulin listed on the WHO. 1985, we had the first pens. 2000, we had the first analogues. And in 2021, those long-acting insulin analogues were added to the WHO EML. So these are not new products we're talking about. 40 years ago, there were insulin pens. And today, we don't see insulin pens being used certainly not in the countries where MSF is working, and very limited use in the public sectors in low and middle income countries. And that primarily is because of price, and this is what we want to discuss further today. So I'm going to hand over now. I've got the pleasure of introducing Elizabeth Feaster. She is the founder and executive director of T1 International, and she will tell you more about her organization. Over to you, Elizabeth.
Thank you so much, Helen, and the MSF Access team. Happy to be here today. Yeah, I'll just tell you a little bit about the organization before sharing about the pen survey that we did, and I'll dive into details in a moment. But T1 International is a diabetes organization. We believe in a world where everyone with type 1 diabetes, no matter where they live, has everything they need to survive and achieve their dreams. So while we are primarily focused on type 1 diabetes, because of exactly what Helen said, without insulin, a person with type 1 will die within a matter of days or hours. We work in solidarity and collaboration with people with all types of diabetes. And really, we exist for people with diabetes and are run by people with diabetes. So we're community led. I myself live with type 1 diabetes, as does much of our team and our leadership. And we really work with communities and with individuals to help give them the support and the tools and the training that they need to fight for long-term sustainable change. Next slide. And we are patient-led, as I already alluded to. We really work to center around what the patient community needs. And in tandem with that, we do not accept funding from the pharmaceutical industry or any entity that we think could compromise our ability to speak out freely. As Helen also mentioned, there is a lot of pharmaceutical industry money in healthcare and in diabetes organizations especially. And since our foundations, as a small, scrappy grassroots organization, we have committed to never take funding that we think would compromise, again, what the community most needs. And that is truly most important to us and leads all of the work that we do. Next slide. And again, just to kind of share that in our advocacy work and in our push for sustainable change, we not only want to ensure that the basics of insulin and testing supplies are available to everyone around the world. We fully support this 100% WHO target, although have some questions and wonder how that's going to be measured and monitored, and we're doing some advocacy work around that. But just to name that, it's a really, really complex condition to live with. It's something that 24/7 we have to be thinking about and managing and dealing with. So insulin truly is the tip of the iceberg in the hierarchy of needs. This image here on the left is not a medical image. It's from a person living with diabetes and a personal blog that they created. But it's just to show the concept that really insulin and testing supplies are the very baseline, because there are many other pieces that are needed: access to a healthy diet, access to ability to continually test your blood sugar and monitor it, good healthcare team, mental health support, all of those things. So for us, quality of life is we believe is a huge indicator, and that often is left out in academic and scientific publications. And that really, I think, leads into this pen work as well. And not only do we have some data that I'm just about to share with you, but we can hear from our community that quality of life is absolutely improved with using pens. So next slide. At T1 International, we, again, are guided by our community, and we did a community-led process where we determined what our main global advocacy goal and priority push would be. And so we're pushing for the cost of insulin and glucose testing supplies to be less than 5% of a person's income in every given country. We ultimately think, of course, it should be accessible and affordable for all and free, but it was really important to our community that we have a number that we're pushing towards, so that we can measure progress and hold accountable those in power to try to make sure that, again, the basics and what works best for most people is available to all. So we do have a push for the insulin manufacturers, and we are asking them to make all of their insulins that are on the WHO essential medicines list, which Helen referred to in her earlier slides, make those available for government contract for $2 or less per vial, or $5 or less for a box of pens in low and middle income countries. And MSF is going to share some of their data, which I think supports this in terms of what the cost could be, where the companies could still make a profit. And this image here is of our Global Day of Action, which happened on March 16th. And we delivered, we did actions in over 7 countries and delivered petition signatures to the big 3 insulin manufacturers. We had thousands of signatures supporting this ask, and actions worldwide where folks locally, we supported them to really have this insulin equity now message worldwide. And we will continue those types of actions. Next slide. So about the survey that we did in collaboration with MSF Access team, we reached out to our community and we put together this survey just to really look at, we were hearing a lot of anecdotal data from our community that, yes, if I had the choice to use pens, I would use pens. And we wanted to put some numbers behind that and see what came back when we put this survey out to our communities and to MSF Access team and where MSF Access clinics are. So we had 403 responses from 38 countries, and 88% had used both pens and vials and syringes. And of those that had used both, 82 preferred pens to vials and syringes. So a pretty clear preference for the use of pens. And that's for a number of reasons. And the next slide will show more, but drawing up the correct dose and injecting insulin in public, transporting equipment. There are many reasons that we could see and point to that folks shared that made pens just a lot more practical. Next slide. So yeah, again, here, this kind of goes into more detail of the benefits of insulin pens, thanks to the MSF Access team for building this great graphic. Things like accurate dosing. I've personally used vials and syringes and insulin pens, so can agree with most of what's written here from my own personal experience that when you're on the go, or even when you're not on the go, when you're trying to balance that syringe on top of that vial and get that accurate dose, it's just more challenging than just being able to click, twist a pen and drop that dose. And things like reading, if you have trouble seeing there, that it makes it easier for visual. Pens are encased in plastic, whereas vials are glass vials. So much more robust as well. And some people feel that because insulin pen needles can be quite small, and you can even get micro needles. Again, it depends on where you're living and what you have access to, but it can be a lot less uncomfortable than using what can often be a pretty thick needle on a vial and syringe. And when you compare here the supply of a month's supply of pens and vials, you can again see visually this difference with, as Helen said, with pens, you do need those pen needles that need to be changed, but they're quite small. And as I've been going on about quality of life, just all of these things make it more easeful and more accurate. And we just hear from people that say, I just like pens better and it makes my life better. And that's hugely important to us. Next slide. So you'll see on this briefer that we put out together that it does have a page or 2 about the survey, and there's some great quotes and feedback, but just to pull out a couple here, again, from respondents who basically said, things like syringes would get bubbles no matter what you did to avoid them. Carrying syringes around has more stigma and the vials broke easily. And on the other side of that, it's very easy and great to carry a pen in your purse. There's not too much stigma when injecting. So stigma is it is a really important thing for a lot of the community that we work with. And again, came through in this survey. Next slide. That's the last. That's the end. Great. So yeah, let me pass it back to the MSF Access team, but looking forward to engaging in discussion and answering any questions.
Great. Many thanks, Elizabeth. So I'm going to hand it over now to Krista Sepper. Krista, I'll let you introduce yourself, if that's okay.
Okay.
to now look more into what's going on in terms of what these COP3, the triopoly, is offering us in terms of insulin access. Over to you,
Thanks,
Krista.
Helen. Thanks, Helen. Thanks, Elizabeth. Yeah, so I am going to just try to unpack the access initiatives that have been launched and continue from the big three pharmaceutical companies that dominate the insulin market that Helen has already described briefly. So just to reiterate, these three companies, Lilly, Sanofi, and Novo Nordisk, are these three largest insulin-producing companies that produce just over 70% of the human insulins and over 90% of insulin analogs. They have just enormous profits ongoing, and you can see the kind of average profit margin and earning per share, over 15%, which is already amazing for a return on profit. And then their combined profits from 2022, combined all the way up to over $50–60 billion altogether. And as Helen mentioned, Novo Nordisk, for example, has become the biggest company in Europe and is basically running the GDP of its host country, Denmark. So what are these companies, considering this context, what are they doing to help increase access to the medicines that they basically monopolize the manufacturing for? Next slide, please. So I just wanted to acknowledge some of the work of some of the network partners that work on access to insulin for longer than even the Access Campaign has. So we have the Health Action International XC study that has been going on for some years now that has done a lot of work on unpacking the market for insulin. That's where a lot of the statistics come from. Of course, T1 International, from whom we just heard. There's the International Alliance for Diabetes Action, which is looking specifically at access to insulin in humanitarian settings. And then there's the Access to Medicine Foundation, which launched its first insulin-specific report in 2022. And they're apparently updating it for the end of this year, I believe, 2024, looking at what the pharma companies are doing specifically to expand access to insulin. So I'm using all of our colleagues' work in this presentation. Go ahead, please, Helen. So, I mean, in general, across the companies, they have a number of initiatives, and it is actually quite difficult to understand all of them, to find information about them in a kind of one specific place, to understand the details of them, because they tend to be quite specific, whether it's specific products, specific formulations, specific countries, specific programs within a country, et cetera, et cetera. There doesn't seem to be a full engagement across all insulin products. Some companies specifically focus on human insulin, some on analogs for specific populations like children, and some both. Donations are very common as a model for what they call access from these companies. We know that pharma companies really like to do these kind of donation programs. And then kind of most importantly, we find the impact is not really measured in a meaningful way or a comparative way to be able to say that, oh, this pharma access initiative from Novo or from Sanofi or from Lilly has actually made an impact in a specific way. So just to go through each of the specific companies, first one is Novo Nordisk. They have this eye care program, which is basically like a business development initiative. And probably some of you may have heard about their collaboration with a South African company called Aspen, where they are in partnership to manufacture human insulin in vials for Africa, for the African market. So it's a contract manufacturing initiative through which Novo basically controls the whole supply chain and the pricing and the access and the regulatory initiatives after the manufacturing is done by Aspen. Novo has a number of other initiatives called like Changing Diabetes in Children, where they have treated 52,000 children in about 30 low and middle income countries with human insulin mainly. They do donations to humanitarian organizations like Direct Relief, Danish Red Cross, ICRC, and WHO. And next slide, please, Helen. Yeah, Novo has made an access to insulin commitment, when that is their quote, where they have committed to make human insulin available for years to come. And they guarantee a ceiling price of human insulin in a vial at $3 for low and middle income countries and $2 for organizations providing relief in humanitarian settings. So for example, MSF procures Novo insulin, human insulin in a vial for that price for $2, and we have for many years now. They yeah, so their access to insulin commitment means that they will continue to produce this insulin. But what's happening now is that we find that there are more and more countries where we're observing, and countries are reporting that they're having difficulty procuring, for example, human insulin in pens. So whereas perhaps the vials Novo has committed to, they're struggling now to make the pens available because they have a struggle with their current production capacity. They have supply constraints with human insulin cartridges for both reusable pens and disposable pens. And it's driven, as they say, this is from Novo themselves, by higher than expected demand across a number of products and capacity limitations at some of our manufacturing sites, meaning that their manufacturing lines are under pressure. So they don't say what that means, but it is surmised and it's assumed by people who are trying to procure human insulin in pens that it's because of the pressure from the newer type 2 diabetes medicines that they're making. Next slide, please. Yeah, so this was just about a donation that Novo made, for example, to WHO in 2020, which doesn't really appear to be in line with WHO's own guidelines on medicine donations. Next slide. So Lilly has something that they call the 30 by 30 effort, which they look at 3 key areas, pipeline, programs, and partnerships, which I don't know if you're familiar with pharmaceutical companies and the kind of work that they do, you may question, well, what would be the role of a pharmaceutical company, for example, in some of these things like programs and partnerships? The pipeline makes sense. I mean, manufacturing makes sense. Making medicines available at fair pricing makes sense. But some of these other programs, when you start digging into them, you can have some questions about them. I mean, Lilly as well engages in donation programs through Life for Our Child, where they donate their insulin for children in a number of countries, humanitarian donations as well. They have a business relationship with an Egyptian company called Eva Pharmaceuticals, where they have entered into like a tech transfer initiative with them to be able to produce human and analog insulin for the Egyptian market. And they also have a distribution program with the same company in South Africa called Aspen, but just for distribution of Lilly insulins. Next slide, please. Sanofi has a lot of quote unquote access programs, and it takes quite some time to kind of understand them, because what they have is what they call a global health unit, which was struck a couple of years ago to look at increasing access to Sanofi's medicines, 30 of them in 40 specific countries. It's not very clear on how they chose these specific countries. And they're looking at things like making their analogs available, their insulin analogs available at lower prices in some of these countries. And it's true, even for MSF, we've been able to take advantage of this price offer, and we can buy from Sanofi an analog pen for just €2. So it's actually cheaper for us to buy an analog pen than it is for us to buy a human insulin pen. But they have other programs in this global health unit and impact program, where they're trying to improve patient outcomes, building impactful multi-sectoral partnerships, strengthening health systems. And when you start looking into the details of what they're doing, training of health workers, health system strengthening, you kind of wonder exactly what possibly could be the role of Sanofi in these initiatives, and how are they being measured with respect to their impact. And they have launched a specific brand of their medicines called Impact, Sanofi Impact, where they have rebranded all of their originator Sanofi brands into an actual new packaging called the Impact brand. That for the reasons which they say, it provides more accessible prices for these essential medicines, offering more value to reach more patients. So it's not exactly clear how repackaging them, the same product at the same manufacturing site has led to a lower price. Next slide, please. And this is just a map of where they've launched. Interestingly, when you look to see where they've launched their glargine, they've launched in Tanzania. So they launched this program last year, in 2022, sorry, and they made their first glargine available in Tanzania last year. But yeah, the numbers are not yet quite clear. And it was the second Impact brand medicine to be made available. There was another medicine made available in Djibouti the months before. So they plan on impacting this many millions of people in these specific countries. Next slide. So I just wanted to talk a little bit about the possibility of impact evaluations, because there are entities that exist purely for this reason. So, well, there's the Access to Medicine Foundation, which does its kind of biannual report on measuring the impact or the practices of pharmaceutical companies, and tries to rate them as whether they have impact or not on their pricing and access kind of policies. But there seems to be little motivation outside of an initiative like that for corporations to engage with or to report in a more systematic way or a transparent way. However, it seems that there is some legislation, at least coming in Europe, that may require some minimum disclosures by corporations on their practices and these kind of initiatives. There was something called the Access, well, it still exists, the Access Observatory, but it's lost much of its funding from the big pharma entity a couple of years ago. So they don't have like active programs anymore, but they still have all of their toolkits and their indicators that pharmaceutical companies could, for example, engage in and report on and publish on their websites, which would allow for this kind of comparable reporting, and these indicators from the Access Observatory would show that these companies would be adhering to public health principles. And ideally, they would continue to ask a third party to verify the report, but this doesn't seem to be happening. So last slide, and then back. Sorry, not this one. Next one. Sorry. Yeah. So I mean, there's this kind of massive puzzle of pharmaceutical companies making insulin, trying to have these access programs with a real mix of kind of what their enormous profits are, who they're donating to, what their target populations are, what is their how much profit they've made after 100 years, and what their prices are. We suggest that this puzzle is kind of unnecessary, and if the pharmaceutical companies, these three companies, could simply commit to continued continuity of supply of the medicines for which they have established market dominance over the last 100 years, basically, that it becomes now their responsibility to make sure that they'll still be able to supply these medicines, these essential medicines, to people and to government programs, to end the ongoing profiteering that has just seen their share prices through the roof and lining the pockets of many people, to allow these public health sector programs to function and not be splintered by these different initiatives, projects, and offers. So I think with respect to the ongoing profiteering, I'm going to turn back to Helen to talk about what the prices of these insulins could be. So we know that they're very expensive, and we know that currently pens cost more than generally pens cost more than insulin and vials, but we're proposing that insulins could actually cost much less than they currently do. Over to you, Helen. Thanks.
Thanks, Krista. Yeah, so what could insulin actually cost? So at the end of March, we just published this paper in JAMA. The link's there. We'll share the link in the chat as well. I don't know if Krista, you can pop some links in the chat for people. Looking at these, what we're calling the estimated sustainable cost-based prices for diabetes medicines. A big, horrible mouthful. But basically, what do we think, looking at how these drugs are manufactured, how much should these companies be charging for the medicines? And I want to kind of acknowledge Melissa Barber and Diz Gotham, who we did this work with. So what's in this paper? What we share in the paper are the production costs and estimated cost-based generic prices. So importantly, that means we're including a degree of profit, and we compare those cost-based prices to the current market prices. In the paper, you'll find the prices for both human and analog insulins. There was a paper published in 2018, and what's new in our paper this year is we've included vials, cartridges, and pre-filled pens. We also go on to calculate the annual cost of delivering regimens for type 1 and type 2 diabetes, including the cost of the insulin syringes or the pen needles. We've also got the GLP-1s and SGLT2s, and we'll be talking about those in our webinar tomorrow. So for the market prices, we looked at 12 countries in terms of what was available through publicly available pricing databases. We're not aware of any publicly available medicines pricing data from a low-income country. This again links to our Access Campaign work around pricing transparency. I don't know if anybody on the call is familiar. We've published the last more than 20 years a publication called Untangling the Web on antiretroviral prices. The transparency around what countries are paying for insulin is just not there, and that is a piece of work in itself. But for our paper, we sourced the market prices from the 12 countries listed. Now, not to bore you with the algorithm of how we calculate the cost, but I just want to flag two important points. For the cost-based prices, you will see in the paper there is a range, a competitive formula and a conservative formula. And two main things that are driving the difference in that range is the volume of production. So the competitive formula assumes a much larger volume of production. And then secondly, the profit included. So in the competitive formula, a 10% profit, in the conservative formula, a 50% profit. So what did we find? So this slide, first of all, is looking at the costs per unit. And just to remember, and maybe I should add this to the slide, the vial is 10 mils of insulin, whereas both the cartridge and the pen are only 3 mils of insulin. So I'm just giving the unit costs in this slide. So that for human insulin in a vial, it could cost $1.59, the cartridge $0.6, a pre-filled pen $0.94, and just comparing in red there what MSF procurement prices. So you'll see for human insulin in a vial, we're pretty close to that lowest cost of production, but for a pre-filled pen, we're paying 4 times as much. For analog insulin, and I've just pulled out glargine as an example, all the analogues are listed in the paper. You'll see a vial at 2.83 and a pre-filled pen at $1.3, which again is not so far off what we are currently paying for a glargine pen at $2.11. So if we translate that into the costs per month, based on using 50 units of insulin a day, which we decided to use, that's slightly higher than the WHO daily estimated dose, but it's our experience from our projects in terms of what is being dispensed. You will see if we move from human insulin in a vial to human insulin in a pen, it's going to cost MSF procurement and MSF projects 6 times as much. And for glargine pens, approximately just over 3 times as much. Looking at the market prices, we pulled out, just pulling out for this illustration, India, South Africa, and USA. Lowest cost-based prices for the different types of insulin on the left, and you'll see these crazy markups. So 500% markup in India, in South Africa for human and glargine, 100% markup, and don't even, what's going on in the USA is completely insane. Then what we did in this paper, so you'll see the first table in the paper is the costs of the insulin, giving monthly estimates. The second table in the paper is looking at the regimen. Yeah. So what I've shared here is the cost of a basal bolus regimen for type 1 diabetes. And if we include the cost of the syringes, if you're using a vial, or the pen needles that you need to screw on to the pen, we've demonstrated that actually, if we got these cost-based prices, which include a profit from the companies, moving to an analog in a pen device could cost less than using human insulin in a vial. For type 2, to move from human insulin in a vial to pens, there is a slight increase in cost of $13 per year. So we weigh that against the benefits, the quality of life, all the things that Elizabeth was talking about. But I think there's possibly less of an argument at the moment around moving to analogues. However, I think it's interesting because the volume of insulin that's being used for type 2 diabetes is actually the part of the puzzle that is driving the volumes and driving the market. So I think this will be an interesting to watch this space. So just coming back to our briefer, and hopefully now to kind of start to move towards opening up the discussion, we have listed some specific asks to the WHO, to governments, manufacturers and implementers. Just to kind of pull out a couple of points to governments, we're asking that these insulins, both human and analog, but in vials, cartridges and pens, be included in national EMLs and guidelines, and that, excuse me, and that they are considered in public sector budgeting, even if it is for specific groups of people who might benefit the most from an easier to use device. To the manufacturers, we're asking them to include human and analog insulin and in the different presentations within negotiations with governments. As Krista flagged, particularly with Novo Nordisk, they seem to be in the mindset that they only want to offer human insulin in a vial to countries in lower middle income settings, and not beyond that. So I think what we're asking for is that there should be an offer across products to countries, and then it's down to governments to then decide within their budgetary planning what they would want to procure. So what are we planning to do at the MSF Access Campaign in the next 6 months? So we've just published our costing paper. We've kind of really tried to push the communications around this information that insulin does not have to cost the market prices that these companies are charging. We're planning to do bilateral letters and negotiations with the companies, and then probably move on to these being public letters with more external communication. We're brief. This is the start of the process today in terms of engaging with civil society, both from the Diabetes Civil Society, but also I think what we want to do, and we feel also in our work may have been a gap over the last few years, is bring in the access to medicines community, including the lawyers. Lena's going to speak in a minute. She's a human rights lawyer, an intellectual property lawyer. We need to get this expertise into the diabetes advocacy world. Yeah. We're also planning a submission to the EML for short-acting analogues, and planning a deep dive kind of analysis in some countries where MSF is working around registration pricing and so on, that we can again use for further advocacy. And ultimately, I think we're hoping to work towards World Diabetes Day on the 14th of November. And I kind of put it to you all, based on the costing data that we've presented, is could we dare to really kind of put this ask to the companies, and that T1 has already asked these companies with some fantastic work, that we're asking for $1 a pen. So Lena, I'm going to hand over to you now. If you can introduce yourself, and you're going to kind of facilitate the discussion. If you would like to ask a question, I see there's been quite some great questions in the chat. Thank you for that. But if you would like to raise a question, please do raise your Zoom hand by going, along the bottom of Zoom. And that if you just, it might be on the right hand side, but there's an option there to raise your hand to ask questions. So please do that. So over to you, Lena.
Yes. So I'm a lawyer who works with the Access Campaign. I'm based in New Delhi, but of course have worked in different low and middle income country settings to increase access to HIV and other drugs for other diseases. So I just wanted to highlight a couple of issues. One of the things that I wanted to say is this, that one of the stark parallels to the HIV movement is the double standard. There would be a standard for high income countries, and there's a standard for low and middle income countries. And you can see that in diabetes as well, where in high income countries, most treatment providers would never offer a vial and injection unless, of course, the patient prefers it. While in low and middle income countries, it's the norm to give injections and vials. So you can already see that a large part of this is driven by the lack of affordability and availability of better devices for delivery of pens, And of course, you have the same double standard on human insulin versus analogs as well. So very little availability of analog insulins in the public sector. The second thing I wanted to sort of draw parallel to is the fact that our policymakers in our countries actually listening to what patients want. So many times the discussions that are happening are that we are okay with vials and injections, and this is why T1's survey with what patients want is so very, very clear that, patients do want the pens, and there's a preference not just based on some whimsical grounds, but actually concrete grounds where they feel there's much better dosing, they can carry it, it can reduce stigma and discrimination, a very important point that Elizabeth has raised. And we really need to support this demand for better delivery of insulin in pens. And number three, I wanted to simply say is this, that if we want to expand the length and breadth of access, we need the public sector coming on and procuring the insulin, human insulin in a pen, analog insulins in pens, and other easy delivery devices, but also giving the monitoring tools that patients require. So if you want to really expand access, then we need to go beyond the access programs that pharma corporations have established and start working at what the public sector is doing. And this is where I just wanted to highlight that countries like South Africa are already struggling to procure human insulin pens. And this is very much related to how companies bid or do not bid for tenders in their countries. And in this context, just highlighting that can we monitor the situation of insulin in our country's availability, particularly of the newer devices, and very importantly, what are the pricing? So someone pointed out in the chat that there's a huge markup on insulin products in the private sector, and trade margins can be controlled by government, for example. These are policy tools that we need to start looking at and applying to diabetes. So what are your country's prices for human insulin pens and insulin analogs, rapid and long acting, in the different presentations? If people can actually take a look at that and contribute to that information, it'll be great. Looking at competition that's available, and what type of insulin devices are the national EML. So is it just vials and insulin without the monitoring tools? Is it the pens as well? All of that can be a very important look into what our countries are offering to people with diabetes who are dependent on insulin. So I just open that out with the thought process that, we need to reduce this double standard between high income and low and middle income countries, and support some of the demands that people are making with diabetes for better tools for diabetes care. So opening the floor for questions for people who raised it. Yeah, so Felix, please go ahead, and then of course we will look at the questions in the chat as well.
Hi everyone, Felix Teufel here, Emory University in Atlanta. I think I posted that question in the chat, but there's a lot going on, so I might have kept track of the answers. My question is, or what I'm wondering is, what is keeping competitors to those three big companies that produce insulin out of the market, given that it does not seem to be patents?
Krista, you want to answer that?
Yeah, I am also having difficulty keeping up with the chat. I think I started to answer that one. But indeed, I think the big three manufacturers are so big. They have just enormous, massive manufacturing capacity in these multiple huge manufacturing sites, such that it's harder for the biosimilar companies to match well, first of all, the volumes, but then again on price. So they've just not managed to compete at that level. There hasn't been a biosimilar yet pre-qualified by WHO, biosimilar human insulin yet pre-qualified by WHO. There are just there are many biosimilars of other medicines registered around the world in the EMA and the US FDA, as you know, Health Canada, other stringent regulatory authorities. But for insulin, it's less. There are a few, but not that many. They've just not managed to compete.
And just to add, I mean, I think what they are producing is often within the local market. And as Krista said, WHO in 2000, and I think Krista, correct me, was it 2019? They launched the first ever pre-qualification process for insulin. And the only company to submit was one of the big three, which is kind of completely pointless, to be honest with you. Yeah? So yeah, it's a very difficult, I mean, Lena, I don't know if you want to comment from the Indian generics perspective, but the fact that an Indian generic has not managed to break that triopoly is quite something. Yeah, it's really quite something that I think you know, needs to be exposed. And then what we see is contract manufacturing in South Africa, contract with Venovo, contract manufacturing with Eva Pharma in Egypt, which is a Lilly initiative, but not a biosimilar scaling up to really kind of compete with those big three. Lena, I don't know if you want to give that generic perspective.
So Elizabeth has put up some blogs, but what I wanted to highlight is that in terms of volumes and scale, we don't have the equivalent of a Serum Institute like we do for vaccines. And this is something to really understand why the Koreans, Indians, and Chinese have not been able to compete internationally, and why 90% of the insulin market still remains with the big three. It could also be largely because of the marketing strategies that the three companies have had. But we really need a much more in-depth analysis of this. And to be very honest, we did anticipate in 2019 when the WHO opened its doors for quality assurance that this would happen, but it did not happen. So we can discuss this as we go along in the diabetes movement. So Kirsten, over to you. Yeah, go ahead.
Thank you. Hi, my name is Kirsten de Klerk. I'm from SA Diabetes Advocacy, a nonprofit advocating for people living with diabetes in South Africa. We have been in talks with MSF over the last couple of weeks regarding the movement towards vials and syringes instead of insulin pens. This is possibly one for Elizabeth, working with Type 1 International, and I've seen a lot of your campaigns globally, as well as maybe for Lena, if you've had any experience in the HIV space. But I wanted to know what you've seen works, and it's a discussion that we had with MSF, where they said the community needs to come forward and start speaking up about this issue. So in terms of advocacy, what have you seen working in that space? What do the community need to do to come forward and speak up about this? Thank you.
Yeah, so just to take that question, I think what's happening in South Africa, of course, your heart goes up. Here's a government who wants to procure pens and is putting the money down for it for almost 15 million pens, and the company does not bid. And I think this is where, from the HIV experience, where we've seen in the early days of HIV that you had corporations who were failing to supply low and middle income countries. And I think this is where talking to the human rights lawyers who represented people living with HIV, whether it's Section 27 or talking to HJI, is very crucial. How do you get a pharma corporation to participate in a national tender is a very key question that we need to ask, because if they are these only suppliers or limited suppliers, and they choose to prioritize something else globally and leave middle income countries like South Africa behind, then we need to look at legal options of forcing them to do so. And a large part of this is also speaking up and witnessing what's happening to South Africa, because that will give voice to others to come forward. And this happened in HIV when South Africans came forward, with people living with HIV came forward saying, this is our problem, this is what pharma corporations are doing to us. Others joined them in that battle. And I think this is really very crucial. Solidarity at this point with South Africa is absolutely crucial, because what we heard about what's happening in Pakistan, what we are hearing about other markets, is that we have companies choosing to step out of the market at given points of time. And I think this is something, public actions, press releases, seeking legal aid from human rights lawyers, all I would put everything on the table as a tool to address the South African situation. And I'm over to Candice and anybody else who wants to answer that question. Yeah.
Yeah, I'm happy to chime in about sort of the advocacy portion of what works, and just from our perspective as an organization and what we've seen historically. I do think that it's great to see that WHO has prioritized this with the Diabetes Compact. So glad to be working with MSF team on this. And I think we saw with the HIV and AIDS movement, there was so much more funding and finance put towards solutions, and a more, I guess, diversity of groups that were fighting and continue to fight the fight that are pharma free and free from industry influence. And I think, there are very, very few voices out there that are truly independent, that can also be the voice for other organizations. So we have a network spanning over 25 countries around the world, and we've heard that they can't speak out, but we are able to speak out when they can't. And I just think creating that community and being able to have this independent voice is really, really, really crucial. And I think there's a huge gap in the diabetes space and a need for more financing and funding that's not pharmaceutical industry financing or entities that are deeply intertwined with the pharmaceutical industry. And then the other piece of this, I think, is again just making sure that all of this advocacy is led by people living with diabetes, those most impacted by the condition. And again, that's when we've seen some of the most successes. There's incredible academics and legal minds that have also led the way, but without making sure that people who are living with the condition are genuinely treated as the experts they are and included from the ideation phase to the completion phase. I think we're not going to get as far in this diabetes access to insulin movement unless more and more groups are continuing to do that more and more.
Yeah, thanks, Elizabeth. So I'm just referring back to Lewis's comment, about the new manufacturing facility in Brazil. And as Krista said, we're trying to find out more about it, and we can share more once we have more information about it. So yes, any more questions that anyone would like to answer? I see Ujjwal is there from who's looking at competition and has been very keen to discuss the lack of competition in the diabetes market. And I'm very glad that we have consumer-based organizations also engaging on this very important issue. So if anyone else has a comment, please feel free to put up your hand. Yeah, so there's a question from Felix, and Ujjwal's hand is up. So Ujjwal, unmute yourself and go ahead and speak, and then I come back to Felix's question.
Thank you, Lina. Thank you. But I'm looking things from competition policy angle, but not exactly looked into this whole episode of insulin and the study that you shared widely, and we also shared widely and with this campaign. But I feel that there are issues like what Felix has said, that if there is no patent barrier, why there is a monopolistic behavior in this? So there is a market, there is an opportunity, why people are not coming? So there must be some entry barrier that we need to investigate from competition policy angle. And some of the smaller examples like lack of interoperability of cartridges in the plate. That is also a competition policy issue, in fact. So these are the few issues that has come to my mind. And I was wondering whether the regulation for biosimilar, whether that is more stringent than required, is more restrictive than needed in order to give a quality medicine, may also be looked into in this matter. If regulation of biosimilar is more restrictive, that can be one of the barriers to entry for the newcomers. Since the profit markup is so huge, I don't think the scale of manufacture will matter at this point. So,
Okay. So, so Ujjwal, I mean, it would be very interesting to look at the markups in the private sector. But of course, what Helen has highlighted to us is that our governments need to negotiate better prices, as MSF has. And I think maybe highlighting at the India level these prices to the Indian government that, you know, there are options. We would very much like your support in whether it's the Ministry of Health or competition authorities, and we can brainstorm on how to do it later with the other actors in India as well, who are actually directly impacted by diabetes.
Sure.
It's wonderful
Sure.
to have you here. And
I'm also a learner, so I'll learn more.
thanks. So Felix says, what research is needed to inform action on insulin access? Of course, T1's survey is really very important, I think, to inform action. But if there's anything else that anyone can think of, Elizabeth, Krista, Helen, over to you on what research, whether it's social or medical, that we need to do to inform this action on greater access to insulin.
Yeah, I'll go briefly. My colleague Shana Casper mentioned it in the chat, but I think one thing that we think is important, and I know someone else raised this by saying, you know, pharmacies will raise the prices even if the costs are lower. And that's why we look at out-of-pocket costs that people with diabetes are actually facing, regardless of what the government price is or what the available price is. We still need to look at all of those pieces, but I think really looking at the cost to the person or the family and what proportion of income that makes up, what level of rationing, so not taking enough insulin, are they engaging in? And that's something that we saw a gap in and have tried to do every 2 years to carry out this data, but it's a huge undertaking, and it's really just a tip. Again, I use this phrase, the tip of the iceberg, but I think there's more that can be done locally. I think we all know the problem exists, but I think it helps governments and stakeholders to see more hard data. So I would encourage more of that type of research to be done locally as one piece. There's a lot of things, though. I'll leave it.
Yeah.
I'll just
Helen,
add,
you want to? Yeah.
I'll just say qualitative work. There is so little data from lower middle income countries. We saw this with the EML applications for the analog insulins. IADA, the International Alliance for Diabetes Action, is one of the partners is doing a study in Bangladesh and Tanzania called the Human One trial, looking at switching from human insulin to analog insulin, just to get that data from a lower middle income setting. But I will say again, the qualitative piece, which is so important when we talk about you know, how people living with diabetes can manage their daily lives. I think that qualitative stuff is so important, and that's certainly something we're trying to do more of in terms of qualitative research as we change our practices in MSF programs. And Lena, I think we're going to have to wrap it.
We are going to wrap up.
Way forward.
On the way forward, I just wanted to say this, that we have everyone's contact details. We'll try and keep in touch, create some kind of forum, or you know, integrate into the forums that we already have. And some great questions that have come across, and please do reach out to Elizabeth, Krista, and Helen for any of your queries after the workshop. I just wanted to sort of highlight there's Jerome from Refugee Diabetes Association, that Ida had a fantastic discussion on you know, access to diabetes treatments in humanitarian crisis, and we can share more information. I don't know where you're located, which location you're looking for, but I think humanitarian actors would be able to respond to some of your queries about refugees and where they are being included in diabetes care. So we'll be in touch, Jerome, offline, and please feel free to write to us. So winding up over there, and if you all agree, when we write to you, to include you in the e-list or any other forum that we may create in the future, and send updates as well, both from T1 and MSF. So thank you, everybody.
Thank you. Bye.